Hypertension awareness. We continue with hypertension awareness series in the young, and today we are looking at drug therapy in a young black patient, a practical guidance. And this is where real-world clinical decision making truly matters as you decide when to start and what to start with. Young patients with severe hypertension need early, effective, and sustainable BP control to prevent decades of silent vascular injury. What are the core principles? Severe BP, more than 160, 100, lifestyle alone is not sufficient. You need combination therapy from the word go. And you choose drugs with strong BP response and organ protection. Simplify therapy to improve adherence, fixed dose combination. So what is the preferred initial approach to many black young patients? Calcium channel blockers should be key in your protocol. Examples are like amlodipine or nifedipine LA. Include thiazide or thiazide-like diuretics, things like hydrochlorothiazide, chlorothalidone, or idapamide. These combinations often produce stronger BP reduction due to the lower renin pathophysiology seen in many African ancestry. Most guidelines recommend dual therapy from the word go once hypertension is diagnosed. So CCBs plus your thiazide or thiazide-like diuretics. When do we add last blockade, your ACE or ARBs? These are particularly important in diabetes, kidney disease or albuminuria, LV dysfunction, resistant hypertension. And you all know the examples, ACEs like enalapril, palidopril. ARBs examples are losartan, telmisartan. When the BP, even if the BP response is modest, organ protection is substantial, especially kidney protection. Beta blockers, when do we use them? They are not usually first line for uncomplicated hypertension, but they are valuable, especially in cases of tachycardia, hyperadrenergic state, and anxiety. If there is cardiomyopathy, if there is a suspected secondary hypertension with sympathetic activation, and the beta blockers are bisoprolol, carvedilol, nebivolol, and metoprolol. Very key is use of single pill combination therapy, and this is encouraged to improve adherence. It achieves faster BP control, reduces therapeutic inertia, and simplifies long-term treatment. So when you are choosing your medication, choose fixed dose combination. You can have CCBs plus ARBs, CCBs plus thiazide, or even triple therapy, CCB, ARB, thiazide, especially for markedly elevated BPs. These have complementary mechanisms and they have stronger BP reduction and better adherence. For the young patient, your goal should be below 140/90 and progress below 130/80 if tolerated. The young patients benefit profoundly from early aggressive but safe control. The clinical part in these young severe hypertensives: treat early, investigate for secondary causes simultaneously, follow closely, and simplify therapy, fixed dose combination. This is how we prevent decades of cumulative vascular injury. With timely therapy, adherence support, and close follow-up, many young patients can achieve excellent BP control and avoid complications. Early control is not just treatment, it is protection of future life. So which drug combinations has given you the most reliable BP control in the young patient? Stay tuned for our final episode in this awareness series of hypertension in the young, where we will wrap up the practical approach to the patients we introduced in the beginning of the week, the 32-year-old young patient with a BP of 175/111. Dr. Muthui-Mutua, saving lives one heart at a time.